So I am a lung cancer medical oncologist at Princess Margaret Cancer Centre in Toronto, Canada. My background has been translational research focusing on targeted agents and in particular resistance mechanisms in the laboratory and in the translational setting, as well as clinical trialists focusing on rare subtypes of lung cancer, including ALK and ROS1. Non-small cell lung cancer treatments are now completely segmented by the subtype of lung cancer. So there are at least a dozen different subtypes of lung cancer, all with different treatment regimens and treatment sequences, as well as different prognosis and different sequence of drugs going down the line. So in essence, I consider lung cancer to be a large series of rare tumors, all that happen to be occurring in the same organ system. ROS1 is just one of them. It's a very rare subtype occurring in approximately 1 to 2% of lung cancers. I'm going to start off a little bit differently so that there's some context as to what the unmet need is right now. ROS1 patients have been fortunate over the past half decade or so because of the development of specific drugs that target this population. The first drug that came out is crizotinib, which has an approximate progression-free survival median value of about 1.5 years. And the second drug is entrectinib, which has very similar outcomes, except it has a better performance when it comes to controlling intracranial disease. The third drug that came out is repotrectinib, which is a drug that has roughly doubled the progression-free survival of the first two drugs, but has significant toxicities associated with it. So currently, the unmet need in this particular setting is both improvement in efficacy. We want median progression-free survivals longer than roughly 3 years with repotrectinib, and significant improvement in safety in the sense that there are a lot of unusual and difficult to control side effects with both entrectinib and repotrectinib. So taletrectinib is a drug that was being developed specifically to improve on both the efficacy and safety in the setting of ROS1 patients. And the treatment for ROS1 is generally divided into two groups: newly diagnosed individuals who have not received any prior tyrosine kinase inhibitor or oral drug related to ROS1. And the other group are those who've received a prior tyrosine kinase inhibitor or TKI drug. And the TRUST trials involve the evaluation of taletrectinib in both of these groups. TRUST 1 is actually a China-only study. So TRUST 2 is the global version of this study to ensure that all the results that we see in the Chinese population are replicated and seen in a much wider global population. So I will be presenting the data on TRUST 2. So TRUST 2, as I mentioned before, has two main cohorts, and I will speak about them separately. Those that have not been treated before, so the TKI naive, and those that have been pre-treated with either crizotinib or entrectinib. In other words, a prior line of a TKI. So in the patients who are TKI naive of ROS1, the objective and overall response rate is sitting at 85.2%. More importantly, after 20 months of follow-up, the median duration of response, as well as the median progression-free survival, have not been reached yet. The curves themselves look very similar between TRUST 2 and the data for TRUST 1. In fact, the data from the two trials were pulled together when submitted to the FDA, and there the duration of response and the progression-free survival of the data that went into the FDA was greater than that of all the prior drugs and sitting in the mid 40-month range, so about 44 to 46 months in this setting. From an efficacy perspective, in the first-line setting, it definitely is an improvement upon what's available now. When it comes to pre-treated, so previously patients who've been previously treated with crizotinib or entrectinib, the efficacy outcomes are also impressive, with an overall response rate of 61.7%. and a median progression-free survival of 11.8 months, but a median duration of response of 19.4 months in this setting. But also important is the fact that taletrectinib has a safety profile that improves on the previous two drugs, that is entrectinib and repotrectinib. First of all, the main side effects of taletrectinib appear to be that of a GI related, so diarrhea, nausea, and vomiting. However, when you dig a little bit deeper, these side effects occur very, very rapidly, but also disappear very, very rapidly. So they're quite self-limited, often starting with the first dose, so the first couple of doses, and disappearing by the time we reach the 1 week mark. On top of this, there are some abnormalities that can occur with the liver enzymes, but that can be dealt with in a very similar way as crizotinib. When you get to grade 3 or higher, you can stop the drug, temporarily interrupt, and then restart at a lower dose. And that seems to work quite well for managing this. But most impressively, the main side effects that bother patients for both the prior drugs, entrectinib and repotrectinib, are those related to TrkB inhibition. So in other words, they are neurological side effects such as a change in the taste, as well as lightheadedness and dizziness that sometimes is hard to control. Taletrectinib's side effect profile is significantly improved with really mild grade 1 dysgeusia, as well as with dizziness, and with numbers that's substantially lower in both frequency and severity compared to these prior drugs. Only 2.3% of patients discontinue treatment due to treatment-related adverse events in this setting. So from an overall perspective, it does seem to be that taletrectinib dominates over the existing other drugs that are FDA approved as well. From a practical perspective, if you have a patient who's newly diagnosed with a ROS1 fusion, it makes great sense to use taletrectinib in this particular setting because both from an efficacy perspective and a safety profile perspective, taletrectinib will be much easier to use from both the patient's perspective, but also from the oncologist's perspective. If a patient has been previously on crizotinib or entrectinib, there's very clear data that patients can benefit with taletrectinib as well. So in pre-treated patients, taletrectinib would be a good choice to use and add on to the number of drugs that we have available to use in this setting. There's also anecdotal data outside of this trial that suggests that taletrectinib can be useful even after drugs such as repotrectinib, although that data is quite limited at the moment. So in brief, I think taletrectinib adds to the drugs that are available and should be definitely considered for use in this rare patient population.